Good afternoon, everybody. Thank you, Dr. Ashta, for organizing this meeting. Thank you for inviting the rheumatology team. It's quite well attended. It's really impressive, and it's impressive also that everybody is still, the attendance is still going on up till now. That's very, very impressive, really. So I'm Dr. Sharlala, Hisham Sharlala, 20 years in rheumatology department. It's surprising that 20 years in Barnsley and I've only seen few faces. So we know each other probably from letters, but the first time we're meeting face to face. As my talk is about polymyalgia rheumatica and temporal arthritis, I'll try to make it as practical, simple, straightforward, what we do in rheumatology and managing these conditions. So I'll be talking about the epidemiology of polymyalgia rheumatica and temporal arthritis to have an idea how much patient workload you expect in every surgery. And I will be talking about a few cases, real cases we've seen in the rheumatology department. Please give me an indication when it's 5 minutes. So polymyalgia rheumatica is the most common inflammatory arthritis, especially in the older age group, so over 70, you see this is the most common inflammatory condition. But the problem is that it's a very vague condition. An accurate diagnosis is not always easy. We should always, like in fibromyalgia, the other kind of presentation, younger people, we need to think of differential diagnosis. Is it rheumatoid arthritis presenting, as Dr. Krut was saying in her presentation? Is it a rheumatoid presenting in a form of polymyalgia rheumatica? Is it a connective tissue disease? Is it this RS3PE? And that's the explanation. Relapsing symmetrical seronegative inflammatory arthritis. Again, responds to steroid very well. Is it osteoarthritis? Is it septic? Is it another sepsis? All these possibilities need to be taken into consideration before we come to a conclusion that it is polymyalgia rheumatica. And just to test the technology, so what's the size of, to have an idea, what is the expected workload of this kind of presentation? What is your size of surgeries? You want to vote on these?
They've already voted, 1 second.
Oops. So majority are 10 to 20,000. So that will give me an idea how much the workload for these conditions. The criteria for making the diagnosis of polymyalgia rheumatica. So it needs to be the patients over the age of 50. So it is very essential to not really make easily a diagnosis of polymyalgia rheumatica, even if they fulfill all the other criteria. 30 years old, we have seen some patients being reported very rarely as polymyalgia rheumatica, but this is an extremely rare diagnosis under the age of 50. So they present with bilateral, it's essential bilateral shoulder stiffness, shoulder pain. Over the age of 50, abnormal inflammatory markers with these additional features. And every feature has its significance, and the points will give the significance of each of these manifestations. So morning stiffness for more than 45 minutes is very important. It is given 2 points. If there's in addition to bilateral shoulder involvement, if there's hip pain, limitation of range of movement, and this is again new onset hip pain, it's given 1 point. Normal rheumatoid factor senior ACRA is given 2 points, because that will exclude and rule out the possibility of rheumatoid and the absence of other joint inflammatory joint symptoms. So if you score 4 on these, the sensitivity for detecting a correct diagnosis of polymyalgia rheumatica is over 70%, and the specificity is about 60%. And the bottom line, this is more specialized in some centers where they use ultrasound and they detect synovitis and inflammation in the shoulders and the hips. And this adds and increases the accuracy of making the diagnosis. With temporal arthritis, again, they need to be the elderly. The older, the more likely the diagnosis to be correct. We very rarely see patients around the age of early 50, 51, 52. Very, very uncommon. It's more likely to be over the age of 70. But it is one of the criteria. So new onset localized headache, tenderness and loss of the pulse of temporal artery, raised ESR but not 20, 25, 30. Usually they have ESR of 70, 80. That's a quite significant inflammatory response in a typical temporal arthritis. And then when you refer to us, the temporal artery histology will show the abnormality in the histology, granulomatous infiltration, acute and chronic inflammatory changes. So if you have 3 or more, the sensitivity for the diagnosis is 90%, and the specificity is 90% as well. So you look at the epidemiology, the incidence of polymyalgia rheumatica seems to be more common in the northern hemisphere. So the colder, we don't know exactly what is the cause of these conditions. Do they see it? Are they more susceptible to viral infections? It's not very clearly understood, but in epidemiology studies, in Norway, the incidence of the condition is up to 112 in 100,000 population. In Italy, it's only 12 out of 100,000. USA is about half, and the UK is probably the same. And so you expect one new in 2000 practice, one case per year. We had a in the UK, primary care epidemiology study which looked at the prevalence of polymyalgia rheumatica and giant cell arthritis in people over the age of 55. And this is the incidence, the prevalence of giant cell arthritis and polymyalgia rheumatica. And they found that women are more commonly affected. So the lifelong risk of developing polymyalgia rheumatica is about 2.5% in females and 1.7% in males. So prednisolone is the treatment of choice. It's the commonest indication for using steroids. That's probably why rheumatologists, they are famous for, what are you good for? Just prescribing steroids. Why refer to rheumatologists? Everybody you treat with steroids. But in fact, our role is exactly the opposite. We try to minimize the use of steroids and only use it where it is absolutely essential. So we have to exclude the other possibilities before we make a diagnosis of polymyalgia rheumatica. So I'm going to present cases that we have seen. We'll vote on how you think these cases should be managed. The first patient is a lady, 75 years old. In February 2012, she presented with acute pain, stiffness in both shoulders, and also pain in the hips. So if you look at the criteria, is she scoring points on these classification? Morning stiffness for 2 hours, and so acute illness. She doesn't have any pain in the hands, no skin rash, no localizing signs, no other sinister manifestations. So you think that this is likely to be polymyalgia rheumatica. So at the practice, urgent bloods were organized, and she does have significantly abnormal ESR and CRP. So the impression is polymyalgia rheumatica. So how do you think this patient needs to be managed? Start prednisolone 30 milligrams and then refer to rheumatology. Refer to rheumatology urgently without starting steroids, or start steroids 15 milligrams and assess in your surgery in 2 weeks' time.
More than half of them have already voted.
Good. So I would agree with these.
Sorry, which one would you agree with?
So the majority voted for starting the steroids and reassessing the response to the steroids, both clinically and hematologically.
One second. Oops.
So the patient responded well. So after the patient has now responded, there's no pain, the repeat blood test shows normal inflammatory markers, what would be your next action? Would you refer to rheumatology or plan a gradual reduction in steroids? Okay, so I'm glad we all in agreement. So it's a straightforward condition. The next is, so you keep on reducing the steroids by 2.5 every month, aiming to stop the steroids in 6 months. So the commonest pattern will be majority will respond to steroids if the diagnosis is right, and if it's a mild case, they will be off the steroids in 6 months. Some will require a slower reduction of steroids by 1 milligram every month. Some may require the even slower reduction of steroids. But these patients kept on having recurrence of the symptoms. Every time the steroid dose reduced below 10 milligrams, they have recurrence. But you increase the steroids to 15 milligrams, 12 and a half, the patient is responding very well. So what would you do? You keep on giving this to the patient. The patient is demanding steroids. She's feeling better on the steroid, on 15 milligrams. So would you continue the prescribing of the steroids every time the symptoms recur, or you refer to rheumatology? Right. So I agree with your response. So obviously this patient is having recurrence of the symptoms. They are not able to get the steroids, but what do you think we will be able to do more than you are doing? So what do you think is our role now? Any
Would you put them on a DMARD or something?
I think number one role is that to confirm every recurrence is due to polymyalgia rheumatica. These majority are 70, 80 years old. There's nothing to stop them from having osteoarthritic pain. And they want to replicate the excellent experience they had when they started steroids. And they want to be completely pain-free. Every time they develop painful joints, it's polymyalgia rheumatica. Can you increase the steroids? So it's very important that we confirm their symptoms are still inflammatory. The inflammatory markers are rising, and it is what they actually require. The other thing is that it's very important, and as Sabiha was saying, that we can use steroid-sparing agents. When we feel it's necessary, we are not able to reduce the steroids below 10 milligrams, we will introduce azathioprine, we will use methotrexate for these patients. And they do respond to that. So the second patient covers another aspect, another kind of presentation. An elderly, 78 years old female, presents with acute onset headache. She has tenderness on the right side. She has also described intermittent jaw pain. She felt unwell, had been off her food. She had some possible polymyalgic symptoms, but no visual symptoms at all. So she has tenderness in the right temporal artery, but it is pulsatile. Stiffness in shoulders, and no other abnormalities on examination. Urgent bloods were organized, and she does have significantly raised inflammatory markers. So what would be your next plan of action? Would you refer to rheumatology, refer to ophthalmology or start the patient on steroids and refer to rheumatology? What's your response, please? Excellent. So I'm glad that we're all following. So if it is what the BSR would recommend, patients with symptoms of temporal arthritis need to be started on steroids immediately, 60 milligrams of prednisolone, depending on the body size, and then referred to rheumatology. So this is the suggestion is to refer urgently by sending a fax referral form to our secretary, Jawan, who will pick it up and give it to one of the rheumatologists who will make a decision and see the patient as soon as possible, and then decide on the arrangement for temporal artery biopsy. Some cases we do resort to organizing a PET scan. Unfortunately, in Barnsley, our radiologists, they don't do ultrasound of the temporal artery. The service is a bit stretched at the moment. If the patient does have ultrasound before the steroids or within a few days of starting steroids, you do get the halo sign, very useful sign for diagnosing temporal arthritis. But the service is not available. And we will arrange...
Just hold the microphone a bit closer.
Sorry. We will arrange the referral to the ophthalmologist for assessment as well. So 2 weeks later, the ESR normalized, and the steroids will be reduced by 10 milligrams every 2 weeks until the dose is reached of 20 milligrams, and we slow down the reduction of steroids. And they usually need the steroids for up to 2 years. Patient who's confirmed temporal arthritis need to be on steroids longer, much longer than polymyalgia rheumatica symptoms. And very recently, I've seen a patient who was diagnosed with temporal. The history was very suggestive, was diagnosed in primary care. I don't know, for some reason, the patient wasn't referred to secondary care and responded very well to steroids. Symptoms disappeared, and the steroids were very quickly weaned off. And the patient was off the steroids in less than 4 months and was absolutely fine up till that point, but then presented with acute stroke. And I was asked to see the patient on the medical ward. The history was very suggestive of temporal arthritis initially, so we asked for a temporal artery histology, although it's a delayed timing for the histology, and it did show features of temporal arthritis. So if the steroids are weaned prematurely in temporal arthritis, we can end up having serious complications. So the other recommendations is that these patients are at risk of developing stroke and vascular complications. So they need to be started on aspirin. We need to consider bone protection and regular check for possible steroid-induced diabetes. And the bone protection we recommend in patients who are under the age of 65, if they had a history of fracture, then they are at risk. They need to be on calcium and vitamin D. Everybody needs to be on calcium and vitamin D. If they had a fracture, they need to be on alendronic acid. If there is no history of fracture, no risk factors, then it's reasonable to do a DEXA scan and see if their bone density to start with is normal. They're having good response to steroids. You are managing to wean them off the steroids quickly. Maybe they will not need to be on a bisphosphonate. Thank you. So the third case, another 80 years old gentleman presenting this time with acute onset headache, scalp tenderness, he had jaw pain, jaw claudication, and tongue paresthesia. He complained of blurring of vision, double vision, no polymyalgia rheumatica symptoms at all. So the examination, there is severe tenderness in temporal artery, which is not pulsatile. You can't feel the pulse. Urgent blood shows significant inflammatory response. So it's obviously very clear. It's suggestive of temporal arthritis. So what would be your plan of action? How would you deal with these cases? If you can vote on these. Do you start the steroids? 60 milligrams, they're very close to each other, but it's very important. 60 milligrams and refer urgently to rheumatology, or refer to ophthalmology, or the third, refer to ophthalmology, start on steroids, and fax referral to rheumatology as well. What is your response? Excellent. So this is what we expect you to do. But why do you think in the first case we suggested referral to rheumatology? In the second, it's important that the ophthalmologists are the first line of response to you. The visual symptoms. So what would they do more than? They will start the steroids.
They'll check them out for non-ischemic, arthritic, ischemic optic neuropathy.
Well, so they need to exclude other conditions that may present with acute glaucoma and maybe other possibilities, but also they will have to be the patient will have to be assessed by them for the features of ischemia, and they will also get us involved. We will start the steroids, and sometimes we'll admit some of these patients and give them a higher dose steroids intravenously, a pulse of methylprednisolone. So fourth case, a lady who's 48 years old presents with acute onset pain and stiffness in the shoulder and pelvic girdle. She has also some knee and back pain, no swollen joints, no other localizing signs. And these are the results of the urgent bloods you've organized. The ESR is 75, CRP is 50, rheumatoid factor is negative. Does this patient fulfill the criteria for polymyalgia rheumatica?
Yes.
Right, so what is your plan of action in these patients? You refer to rheumatology or treat as polymyalgia rheumatica with 15 milligrams steroids, or refer to medical. You want to vote on these? So you refer to rheumatology. And quite significant percentage will treat as polymyalgia rheumatica, and only a minority will refer to medical. So that's interesting. We'll see what happens next. This patient actually was started with 20 milligrams steroids, and 2 weeks later she felt better, inflammatory markers improved, and they continued the management as polymyalgia rheumatica. The steroid was reduced, but every time the steroid was reduced, she has worsening of the symptoms, and the inflammatory markers are rising. And she started complaining of feeling weak. She's having difficulty walking up the stairs. She's having difficulty getting up from a chair. And she also complained of shortness of breath. And this is new. She didn't have before. So she was then referred to rheumatology. There are a number of possibilities, and everyone could be the actual diagnosis. But what do you think is the most likely possibility in these case scenarios? You want to vote on these? It's interesting. So malignancy obviously has to be considered, and polymyositis is a possibility. This patient, actually, when we did the further assessment, there was no large or small joint synovitis, but she did have quite significant proximal muscle weakness, and she did have fine bilateral basal crackles, suggestive of lung fibrosis. And she was positive for antinuclear factor. We're still waiting for the ENA testing. She has raised CK and LDH. So the diagnosis is most likely, in this case, it's polymyositis, which can be associated with malignancy. So instead of weaning her off the steroids, we have to increase the steroid dose, and she will probably need to be given azathioprine after confirming the diagnosis with EMG studies, muscle biopsies. So the conclusion from these case presentations I've presented to you is that we don't mind, I don't know if my colleagues will agree, the typical presentation of polymyalgia rheumatica, that is scoring all the criteria and responding very, very well to steroids. You are able to wean them off the steroids within the acceptable limit of 6 months from the onset of presentation. We don't mind that these patients are treated in the primary care. But any patient who presents with atypical features, especially the last case, anybody who's under the age of 50, you should be very reluctant in making a diagnosis of polymyalgia rheumatica. And I think these patients need to be referred to rheumatology before starting steroids, because steroids mask a lot of the signs, and it makes it, as Lonnie was saying, it makes it very difficult for the assessment. So anybody who has features of temporal arthritis need to be referred urgently, should not be treated in the primary phase, should be referred. And the temporal artery biopsy, according to BSR, is mandatory. Every suspected temporal arthritis need to have a temporal artery histology. If they have visual symptoms, the ophthalmologist needs to be the first line, and we will be also involved right from the beginning.